Well, good morning, and welcome to the Alzheimer's and Dementia Caregiver Conference. My name is Linda Higueras, and I'm on the board of the Brain Support Network. But more importantly, I am the daughter of Carlos Higueras, who was diagnosed with Lewy body dementia in 2007 at the age of 84. My father died 4 years later, and my family and I realized that he had been showing signs of disease for many years earlier, but he had received multiple misdiagnoses. Today's conference theme is, If I Only Knew Then What I Know Now. And we hope that today's presentations and the materials provided by our community partners will help you navigate the difficult but also rewarding journey as a caregiver. I would like to thank our sponsors today, without whom this event would not have been made available free to the community. First and foremost, the Sonoma Country Day School for allowing us the use of this beautiful theater. The Santa Rosa Press-Democrat and the Sonoma Index-Tribune. The George Peterson Insurance Agency. The law firm of Friedman Goldberg. Home Care Assistance of Sonoma County. The Community Foundation Sonoma County. And the Board of Supervisors of the County of Sonoma, with special thanks to Supervisor Shirley Zane. The community partners are listed on your program, so I encourage you to go to their websites to find more materials, resources, and contact information. And of course, my eternal thanks to the speakers today, who did not hesitate at the invitation to participate in today's conference. They have donated their precious time to us and will be sharing their expertise and their personal stories.
Introduction, Linda, the Brain Support Network, for putting this program together, the Country Day School for hosting it. It's a pleasure to be here with you. Let's see if my slides come up. I see the signal. There we go. So I'm at the Ray Dolby Brain Health Center. I was recruited here recently from Mass General Harvard Medical School, where I've been on faculty. I trained there, and then I was UCSF trained for medical school, did everything else out there. I've been on faculty for 14 years, and the Dolby Brain Health Center is came out of the vision of Dagmar Dolby and Catherine Madison, who took care of Ray Dolby, who was the founder of Dolby Labs. And basically, as you know, it really takes a village to do this right, in the right way. And through a very generous endowment, we're able to actually give comprehensive care. We're growing, and I was brought out as the endowed chair for brain health research to direct the research and education aspects of it. So, and I still actually have my faculty appointment at Harvard Medical School. I still teach there. I apologize up front because I'm going to show you a lot of data. It's going to be at times like drinking from a fire hose, but my PowerPoints will be available to you, and this is recorded. So I want to get the information out so that you hear it once at one level. If you go back and look at it again, I think you'll understand it at separate levels. These are my disclosures. I work with industry, usually to design studies for Alzheimer's disease. I have no stock in any of these companies. My slides are my own. I direct a large program around the world that is looking at finding therapies for Alzheimer's disease in 29 countries, 400 sites, etc. We need to do something better than we have now. I always start my talks with this quote: human beings are members of a whole in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. And this is as true now as it was 850 years ago. I'll show you PET scans and show you p-values and talk about those kinds of things, but it comes down to people and doing the right thing by people. And we can't cure Alzheimer's disease. We can't cure the dementias. We all have an incurable disease. It's called life. We're all going to die at some point. But we want to have vital living as long as we can. And so, it's through that lens that I approach things. And then this is a quote from John Donne, which actually was part of my dissertation. I put it up front about no person Being an island, the title itself, any person's death diminishes me because I'm involved in mankind, and therefore never sent to know for whom the bell tolls for thee. And as Linda said, I actually took care of my aunt when I went to graduate school. She was like a mother to me. And for 14 years, we've taken care of my dad at home until recently. So I live and breathe this. And I know that many of you here are caregivers, and we really need to do something about these conditions. So, what is that? Depends on your perspective. Very good. Well, I'm also a scientist. I also did a PhD, and PhD was in math, actually. So I could say this was 50% by volume, or I could say 50 mLs plus or minus 0.5 of H2O in 100 ml glass, because it's really important for us to be able to measure things, and but ultimately, we'll see at the end of this whether you believe it's half full or half empty. And I'll use the far side. Say we're just a dang minute here, we forgot the cow. Okay. So what is this? Is this is this a slippery slide? The bottom line is that it's really, really important to detect cognitive change from normal aging to cognitive impairment early. And it allows us to do a number of different things. One is really educating, allowing people to be the masters and mistresses of their own destiny. So that's really, really important, even though we have no cures at this point. We have treatments. It's important for care planning to minimize harm, and for people, again, to decide what they want to do with the remainder of their life. And as much as we know, we can't tell you for an individual what the trajectory is going to be. So it's very important, actually, not to take away hope. It's realistic that there's aging. On top of that, if you have a condition, a disease, at this point, people progress. But it's really, really important not to take away hope, and to do everything in our power. And I'll tell you some of those things that we can to slow the trajectory, so that we can really live independently and vitally as much as we can, and then hopefully pass away quickly. It's also really important because to establish practical and healthy habits and ensure up existing abilities. Once you lose a function in the brain, it's really hard to get it back. But even when people have problems learning new information in one way, there's still ability sometimes to actually learn things through habits and then through other domains, and to establish those things early, and establish the support systems early. People who do that do much better in the long term. And undetected cognitive impairment and dementia results in a lot of problems for us. It causes inefficient and unnecessary care at higher costs, and causes harm to individuals and society. It's very, very common, actually, when you look at aggregate data for people. When you look at when they get finally the diagnosis of dementia, and we'll define all those things. When you look back, you see that years before, there were changes in oftentimes in sleep, in anxiety, in their ability to cope with stress and change. People thought they were depressed, so they were treated for depression, even though oftentimes those symptoms are actually not true depression, clinical depression. They're oftentimes withdrawal and apathy. So the other thing you notice is that even if you age adjust for people with similar medical problems, people with dementia cost 3 times more to treat. So years before, people get a whole bunch of treatments that either are inefficient, they put them in the hospital because they can't cope, and it's not uncommon for people for years and years to take a bunch of medications, not take them on and off because they can't cope, end up in the hospital, and that's really, really inefficient. The other things, as you well know, people get taken advantage of. And people can wipe away their whole life savings and do a lot of damage to their relationships in these situations where they don't have a diagnosed condition. Say, Bob, what's a mountain goat doing way up here in a cloud bank? Right, so we don't want to be like these pilots. And, because when that plane, crashes, unfortunately, a lot of people are going to be hurt. It's not just going to be the goat. And this is the global impact of Alzheimer's disease. And again, I will talk about Alzheimer's disease because that's most of our data comes from that. And you can just extrapolate that to the other dimensions. We'll talk about the other dimensions too. But I'll give you just this data for Alzheimer's disease. So when they did the last census, they looked at all the different conditions, the top conditions that cause death. And guess what? In the last decade, what was the only one that was going up significantly? It was Alzheimer's disease. Everything from stroke to prostate cancer, breast cancer, heart disease, HIV, they were all dropping. And Alzheimer's disease was up by 60 to 70%. Okay, and that's even underreported, and that's not even including vascular dementia and dementia with Lewy bodies and frontotemporal dementias. So people are living longer, and we'll talk about the risk factors, and ultimately something's giving out, and the brain's giving out through an organ failure syndrome. Currently, the estimates are just for Alzheimer's disease, 5.3 million. Of those, 200,000 people are young people, below the age of 65. And the estimates are in the next 40 years or so, 35 to 40 years, that number is going to almost triple if we don't do something. And mostly it's because people are aging, okay? What's the impact of that? Well, basically, in 2010, over 1% of the gross domestic product of the world was being spent on dementia and Alzheimer's disease. And those numbers are underreported because all the time that people take to give care, those sometimes are not reported and measured very well. In the US, about $230 billion a year. It's going to probably quadruple or more over the next 30 to 40 years. You've read about what's going to be happening to Medicare. Probably in the next 10 or 15 years, probably 1 out of 3 people, the budget of Medicare is going to be sucked out because of people with dementia, and or more. So possibly it could collapse if we don't do something about it. What's the prevalence? So the prevalence estimates roughly double every 5 years after age 65. So when you look at 60-plus-year-olds, about 2%, and 65-year-olds, about 4 to 5%, 70-plus-year-olds, about 10 to 15%, and once you get into your 80s and 90s, 30 to 50% or more. That's for dementia. That means you've had the cognitive impairment and it's significantly affecting your behavior or function. That is just the tip of the iceberg when it comes to cognitive impairment, because there's a long lead period, we'll talk about it, that people go through stages where they start to compensate for things, and yet they're doing things inefficiently. So this is the School for the Gifted for Dementia and Cognitive Aging researchers, and that's how I feel every day. We need to open the door, and part of that, as you know, is because of there's dementias and ageism. People think, well, they're old, they're demented, what can we do? Treatments don't work. And I can tell you that is absolutely true. When you put everything together, treatments actually, when I mean by treatments, isn't just to give pills. Actually, we'll talk about taking pills away, consolidating care. When you do all those things, it's absolutely meaningful. And we can measure those things, and we measure it on par with many other conditions. But because of this dementia and ageism, we're not funded. If you look at the funding for our condition, for dementia and Alzheimer's disease, a couple of years ago it was about $450 million a year. Now it's going to be going up to about maybe 600 or so million a year from the NIH. That seems a lot of money. What do you think about cancer and heart disease? 5 to 6 billion a year. HIV, 3.5 billion a year. And that's just from the NIH. Okay, and that level of funding has been going on for 30, 40, 50 years. So no wonder we can't attract people and keep them to do research and to have the new ideas and do the long-term studies that we need. So what is dementia? Let's define it. So it's not a specific disease. It's an overall term that says that you've had changes somehow in your mental functions, whether that's memory or thinking, that ultimately is a change from a previous level. If you were never good with names and you're still not good with names, that's not a change, okay? But if you said, Ali, I had a mind like a steel trap for names, And I was very efficient doing stuff at work. And now that's really, really changed. And, so that's something we need to know about and investigate. It's severe enough to interfere with daily function, and that could be at your work or in your home. So it could be that, your ability to manage, for example, the family coming over for Thanksgiving dinner has really, really changed. And you have to continuously rely on looking at recipes and things like that were automatic for you. That may be a condition. Again, that doesn't say you are demented. That means that change has happened. We have to look to see what the causes could be, and to treat all the things we can to support the brain as much as we can. And the other thing is behavior and social function. You can't just say, Jimmy is older, is now eccentric, and that's why he's grumpy, and that's why this and that. We all want to give meaning and excuses for many, many years for someone's behavior changing, their judgment changing, their mood changing. Well, they don't need to remember what day it is because they're retired. Oh, they're feeling this way, not sleeping because they have the arthritis and Flo died. All those are true, but when people finally get to someone like me, when we really look back, we see symptoms 3, 5, 7, 10, 15 years before. And again, it's important if you have changes to think about how you can modify those things. So many different names: memory loss, senility, dementia. So what are the conditions? So if you knew nothing and someone was in their 70s and they had a condition that seemed like dementia, you don't need someone like me. Honestly, if you said Alzheimer's disease, you'd be probably 80 to 90% right. Why? Alzheimer's type of pathology. So Alzheimer's changes in the brain. That doesn't always mean that you're going to succumb to it, and I'll show you why. So Alzheimer's still is the dominant one, and it's not just about memory. It could be about planning and functioning, multitasking, organizing, word finding, being able to navigate around places, judgment, personality. So Alzheimer's disease is probably number one. Vascular changes. It's almost impossible to get into your 80s and not have some wearing down of the small blood vessels that feed everything, including the skin in your legs. Look at your legs if you're above 65 or 70 or 75, and if you see a little bit of hair loss, it's not because of your socks. It's because, no, it's not because of the socks. The skin becomes shiny and you lose hair. Why is that? It means that over time, the little blood vessels have kind of deteriorated, and with it, they're not feeding the hair cells and also not feeding your neurons. And those kind of changes can be seen in the brain also. And so it's virtually impossible to get into your 80s and not have what we call probably a mixed dementia. If that's your cause of dementia, which is probably vascular and Alzheimer's type of pathology. Then, as you know, there are other conditions that go vastly underdiagnosed. So dementia with Lewy bodies or Lewy body dementia. If you think about the spectrum of Parkinson's disease, like Michael J. Fox has, which is very, very different. It's idiopathic, which is a name we make up when we don't understand the condition. Right? Idiopathic. Sounds good, doesn't it? But basically, it means that kind of condition responds to a kind of treatment that increases dopamine in the brain. Okay? Dopamine does a lot of things: coordination of motor function, reward, etc. So Lewy body dementia takes the same kind of pathology you see in one part of the brain and extends it out to other parts of the brain. So it's somewhere between Parkinson's disease symptoms and Alzheimer's symptoms. It turns out depending on the study, somewhere between 60 to 80% of individuals who have dementia with Lewy bodies also have Alzheimer's type of pathology. The symptoms early on are oftentimes major fluctuations in your attention and cognitive functions, having Parkinsonism, okay? So some rigidity, slowness of movements. Sometimes there's a sadness to the face. They're not really sad, it's just they're not blinking. The face isn't moving very much. Loss of postural stability, sometimes a tremor, sometimes not. So Parkinsonism, but not Parkinson's disease in the form that, for example, Michael J. Fox has. And very prominent visual hallucinations early on. So sometimes 10, 15 years before people get to me, they've been having hallucinations but not telling their spouse or their family. I know they're hallucinations. I know it. You know, before I go to bed, you know, I see things occasionally. I've known it for a very long time. Okay? The issue is that when people come later in the course of the disease, I was at the VA in Boston, and I was directed a clinical program there, including a 100-bed inpatient facility for people with end-stage dementia. And we had a palliative care model. And if I took fellows and medical students there and I said, what does this individual have? At the end, it all looks the same, right? In the end, you know, people are not moving, they're not interacting, language function is gone, but that progress towards that, in early on, it allows us to differentiate the different conditions. And now we have what's called biomarkers, we'll talk about that. Then there's the frontotemporal degenerations. And oftentimes, these individuals tend to be younger. It can, oftentimes, a certain variant of it really affects behavior, okay? So people can actually have really good mental functions, but it's actually their personality and behavior that's changed. So the individual who's always been very, very conservative, maybe a pastor or something like that, going in to, you know, doing things that are extremely insensitive and socially inappropriate. So again, if those things happen, in younger individuals, we always think about, oh, is it drug abuse or alcohol abuse? Or is it some sort of psychiatric condition? Older people, if one thinks about anything that could be psychiatric, etc., you have to think about potentially dementia. Okay, so, and then there's a whole bunch of Parkinsonism conditions. Progressive supranuclear palsy, multisystem atrophy, cortical basal degeneration syndrome, and Parkinson's disease with dementia. So individuals with Parkinson's disease, over the course of their condition, over many, many years, the numbers are different, but there are cognitive changes that can be seen in the vast, vast majority, over 75 to 80% of individuals. So one of the things we understand now, and we'll talk about this amyloid protein. This amyloid protein is a protein that's made in the body. We don't quite know what the function of it is. It probably does something in the synapses, which are where the neurons connect with each other, and they have billions and billions and billions of these tiny connections. And really, it's the synapses that are very, very important. The strength of them, the number of them, their efficiency of them. Somehow, we know that in early types of Alzheimer's disease, so for example, patients with Down syndrome, that many of them, individuals, ultimately develop an Alzheimer's type of condition. Or people who have mutations in this gene where they produce too much of this, okay, end up having dementia early. In later life, it may be a problem with us not getting rid of it, okay? We know it's central. We don't know how to treat it yet. We'll talk a little bit about that. But the understanding now is that, you know, it may start depositing very, very early. People go through this phase called MCI, not the phone company they used to be. It's mild cognitive impairment, where if you actually follow people, if you have studies where you get tested, and I get a baseline for you, and over time, for your age and education, etc., your demographics, I can see your trajectory is changing in a way that really is suggested that you're falling off the curve. Oftentimes people go through this phase for a very, very long time. And here, we finally get to do a diagnosis of dementia years after symptoms, oftentimes when people have done something bad with finances, or with behavior, or if they're aggressive, or really, really shocking, repeatedly. And so it's really, really late in the process. So as a background, there's converging evidence that 20 to 30 years before people actually, the organ fails, people are accumulating damage, that a whole bunch of abnormal proteins, amyloid is one of them, it's seen in obviously Alzheimer's disease, but this other protein, tau, is seen in frontotemporal dementia, PSP, and corticobasal, and then also alpha-synuclein, which is seen in Parkinson's disease and Lewy body dementia. There's a whole bunch of issues with these proteins that are not getting degraded, that aren't getting cleared, they're kind of toxic, And we're understanding more and more that there are factors with aging and vascular things and inflammation that affect these things. And the mitochondria, the powerhouses of the cells, need to be functioning quite well. But ultimately, there's a long preclinical phase of Alzheimer's disease and other dementias. And guess what? If there's a long preclinical phase, it means that we may be able to detect it and ultimately do something about it, right? So many of you here probably are on cholesterol-lowering drugs. Is having high cholesterol a disease? Is having high blood pressure a disease? It's a risk factor, right? We've been able to identify a risk factor, right? And say that if you take a statin medication, like atorvastatin, people know about Lipitor, et cetera, like that, that guess what? You take that medicine, 30 of you to 40 of you take that medicine, so one of you has an event for your heart prevented in several years from now. Right? People don't know that. People don't realize that. That actually, right, that probably 30 to 40 people are taking the medicine to prevent one event in one person years from now. Okay? So we need to understand better what these risk factors are for Alzheimer's disease, Lewy body dementia, vascular dementia, and treat them. We'll talk a little bit about that. And we need to sort of elucidate this link between what is the process and how we predict clinical decline. Okay. So this is August Dieter. She was 51 years old when she was brought to a psychiatric institute. Yes, she was forgetful, but what brought her to a psychiatric institute? She had delusions, hallucinations. She was aggressive. She was screaming. And this is Professor Alois Alzheimer's, who wasn't a neurologist, was a psychiatrist. And at that time, we didn't have imaging. The new techniques were you took the brain and you stained it for certain things, and that was the new way of looking at things. And he described in 1901 the condition. In 1906, it was published after she basically died, and the brain was looked at. And it was thought for the next 60 years or so that there's this thing that's kind of rare called Alzheimer's disease that affects young people, because August Dieter was young, right? So they call it presenile dementia, okay? We didn't realize until the 70s and the 80s that, oh my goodness, you know, we're seeing a lot of these kind of changes in the brains of a lot of other people, that actually probably it's not just early onset in presenile dementia, right? It's actually all of dementia that has, you know, that Alzheimer's disease is probably the major contributor. And of course, you know, many of you have seen Still Alice, and we'll talk a little bit about that, not about her particularly. So Alice, I joke around that Alice was my patient. She kind of was. She was an amalgam of my patients. So Dr. Genova, when she was writing the book, before she actually wrote the book, she wanted to know about Alzheimer's disease. And I took care of a lot of people who were very, very bright and were very, very young. So she came to my clinic and saw a bunch of my patients who were professors, et cetera, who were very, very young. And in people who are very young, there's this thing called cognitive reserve we'll talk about. And it's very, very important because potentially it's modifiable, even now, to help us stave off at least the symptoms for long. Okay? Trying to advance here. There we go. So what are the risk factors? Number one, age, okay? So, and women more than men. Women live longer, but independent of that, there's probably something in addition that confers more risks to women than men. So you saw some of the data about age. The other one is family history. Probably if you have a first-degree relative, your chances are 4 times higher. It doesn't mean you're going to get it, but your chances are 4 times higher. The issue is that people don't know their histories. And people, you know, oftentimes 30, 40, 50 years ago died before they show symptoms at a younger age. So again, we know family history is involved. Multiple genes are probably involved that we don't understand all their interactions. Some are probably protective, and some are probably, you know, somewhat contributory. Bad head injury is not good for anyone, destroys synapses, and also it involves a deposition of probably putting people down a pathway that at least another protein, tau, is involved in, which we'll talk about. Poor brain perfusion. Again, everything that affects your blood vessels. So, things that affect your blood vessels, strokes, mini strokes, diabetes, high blood pressure, high cholesterol, smoking, this cholesterol protein, transport protein, ApoE4. We could have E2, E3, or E4. The people who have 2 copies of E4 are probably at 12 to 15 times the risk of developing Alzheimer's. Risk doesn't mean they're going to develop it. And they're probably going to do it 10, 15, 20 years younger than others. If you have one of those, your chances are probably about 6 to 8 times higher or so, and developing it probably 10 years younger than other folks. Environmental stressors, there's a whole bunch of them. Then there's these genes that I talked to you about affecting amyloid. And oftentimes these are seen in families. Half of the people have it through every generation. And if you have one of those genes, then oftentimes we can say, with relative certainty about what age that you can actually show your symptoms. And if you've seen some of the documentaries where people have gone to, for example, Colombia and looked at kindred people who have these conditions, they have some of these mutations. The issue is that we don't test everyone for these. We only test people who have the early onset kind for the most part, and a very, very strong family history of half the people having it. Because even if you have that condition, the vast majority of people still don't have these genes. So the biggest risk factor is this amyloid that I mentioned, this protein of amyloid, that having it, the wrong kind of the brain can destroy synapses. Notice, you can lie about your age, but you really can't change it. You can't change your family history. These things you can't change, but these you can. Okay. So bear in mind you can change a bunch of those things, in midlife particularly. Okay. So it used to be that for those young people, we studied the young people and we said, it's pretty clear. You have this amyloid protein goes awry, destroys synapses, ultimately gets deposited in these plaques that are between neurons, and there's a whole bunch of inflammation. So microglial activation means inflammation, basically. Inflammation comes in, clears out a whole bunch of different things, and then you have these tangles that are inside cells. Neurofibrillary have this tau protein that basically strangles cells from inside. Then you have chemical changes in the brain, so you can have chemical changes in acetylcholine, which is a chemical that if I speak softly, it's going down, you're falling asleep. And if I go like this and I wake you up, it goes up, and it's a kind of chemical that when you wake up in the morning, it boots up in the brain and primes everything else for processing, okay? So guess what? Our initial treatments for Alzheimer's disease affect this chemical. But guess what? It's really late. It's really late in the condition. So the treatments that we have are 2 different kinds. We'll talk about it. One of them is, cholinesterase inhibitors, like donepezil. You've heard of Aricept, for example. Okay, donepezil is the generic form. Ribostigmine, Exelon, galantamine, that tries to boost the level of this by allowing you to process this more efficiently. And then we have another kind called memantine. And use the same type of treatments actually for Lewy body dementia, okay? So it's not really specific. And then ultimately someone does something bad with a car, finances, and is really, really bad, and we diagnose dementia. It turns out that very few things, like I mentioned, in life are binary. So, death, pregnancy, we get those wrong sometimes even. So chances are, if you're older, in your 70s and 80s, you have a combination of vascular and Alzheimer's changes in the brain. And you probably have a whole bunch of other things, including inflammation, and you have a combination of these things. So, targeting only one thing and expecting a magic bullet late in the condition where the organs failed is too late. It's really too late. So what's this concept of cognitive reserve that we all need to hopefully improve on? It turns out that back in '68, when they were counting plaques and looking at a dementia score, so they were counting the number of plaques in individuals' brains, and right before they died, they tested them to see what their cognitive scores are. It turns out the more plaques you have, the worse your score is, so higher is worse on this test. But then they noticed, who are these folks here that actually have a bunch of plaques, but their scores are really, really good, okay? What is it about them? If Alzheimer's disease is caused by these plaques, and if you have a plaque, you have Alzheimer's disease, therefore you should be demented. How come these people weren't demented? Okay? So a whole bunch of other things came along, but ultimately, this also came along, where you look at the prevalence of Alzheimer's disease just through epidemiology and say, by the time you're in your 80s, there's 20, 30%. When they got the brains of individuals before that, of healthy people, and they noticed plaques, look at this. It's almost a parallel curve. And now we're able to see these types of plaques with a thing called a PET scan, a particular kind of PET scan, an amyloid PET scan in the last several years. And so when we look at healthy individuals, we also see that. So these people do not have dementia, they have amyloid plaques in the brain. What's the difference there? About 15 years. 15 to 20 years. So again, we know that people have developed this stuff, but they haven't fallen off the cliff. The risk is higher, it's a risk factor, but what other things can we support to allow them not to fall off the cliff and manifest the dementia syndrome of Alzheimer's disease and things like it? So here are those PET scans I told you about. Blue is good, red means you have lots of plaque in your brain. So in this case, no plaque and cognitively normal, okay? So CN means cognitively normal, testing normally, no dementia, and no amyloid beta plaques in your brain. In this case, look, these two are about similar, aren't they? Look at the plaque load. They look about the same. And yet, this person on the left, cognitively normal. Completely normal. Testing normally, functioning normally, walking and talking, holding a job, okay? Full of amyloid in the brain. And yet this person has not just the beginnings of Alzheimer's, actually has Alzheimer's dementia and has similar amount of amyloid. So in the Harvard Aging Brain Study, you can actually look at this correlation between Alzheimer's dementia, mild cognitive impairment, and people who are cognitively normal, and actually notice that there's a whole bunch of people here who have the stuff in their brain, but they haven't tipped. So we need to follow folks, see what we can do to intervene in the years to come. What is it about some of these people that are protected, and can we actually change their course? And to do this kind of stuff, you need long-term studies, very expensive, and we still don't know what the answers are going to be. I'll tell you a little bit about the prevention trials of people who have this in their brain. Okay, so what's in common here, other than they were both actors? Alzheimer's. They both had Alzheimer's, right? And no matter what you think about Ronald Reagan, he had a lot of social intelligence, right? And it's interesting, he was president until what year? 1989. By 94 or so, quite demented, not knowing the children, not knowing what to do, very demented. Did that happen overnight? It didn't happen overnight. And again, I have no personal knowledge of this, but looking back, I remember that there was this big, I remember I think it was Donald Reagan, I think was his chief of staff, had a huge falling out with Nancy Reagan, and he resigned and wrote a book. Because it turned out that Don Reagan was supposed to manage the whole office and bring people to Reagan, etc. But Reagan was being more cloistered, sort of with a big to the side. The access to him was being restricted throughout the time. And I remember during Iran-Contra, hand goes up, I don't remember, I don't recall. You know what? In retrospect, he probably didn't recall, I think. But again, someone who was very, very bright, functioning, because he was incredibly, he had good language, he had people skills. He could come into a room, crack a joke, said, I agree with this. Yes, we should, be fiscally tight. Yes, we should, have, the Russians do X, Y, and Z, and we should push back, and that's it. Things that are very, very well learned. Okay, cognitive reserves. So think about that for a second. What did they have? What does she have in common with them? She had vascular dementia. Who knows? She had Alzheimer's. Maybe she did. But again, think about it. What a bright lady. What a powerful leader, no matter what you thought about her. And if you've seen the movie and read books about her, it was very, very tough. Of course, okay? Dementia with Lewy bodies. And you guys remember him? Yeah. What did he have? Progressive supranuclear palsy, PSP. So, anyhow, it turns out there's this thing called cognitive reserve. What is it? This is one of the definitions. Individual differences in how people process tasks in the brain allow some to cope better than others with brain pathology. Okay? There's something about some individuals, how they're able, there's hardware that you're born with, there's software that you develop over time through experience, which can actually change your hardware, decide what connections are made, what's gone and what's not. So the ability of the brain to functionally compensate for neurological damage. And again, there are a whole bunch of things about brain reserve, neural reserve, compensation that we can talk about. So basically, you have resilience and plasticity of networks in the brain in the face of destruction. What do I mean by networks? Well, it turns out the brain has specialized areas, but it all works together in a network, okay? And neural reserve is that you're more efficient and have the capacity for your primary networks, the ones that are really honed to do a certain task, that makes them less susceptible. They're just stronger. They're more robust. You smack them with Alzheimer's or vascular, and they're like, I shrug this off. I'm strong. So that's neural reserve. The other part is neural compensation. The ability to adapt and alternate networks and brain areas to compensate for this disruption and damage. What do I mean? So it's like collaterals. It's like, right now, if I came over here today and I got stuck in traffic, I would be doomed. I don't know this area. I didn't know how to take the back roads, right? But people who live in this area have that knowledge. They have the back roads. They can adapt. So they can get here and go a longer way, right? It's analogous to that. If your brain has several ways of getting to information, some are more efficient, some are not. But as the primary ones get hit, you bring in the reserve team, the back roads, the substitutes in a team, and you can still get to information. And it turns out people who are brighter, who have higher IQs, who have studied more, who engage their brain, who've made more connections, they have more of these back roads, they have more synapses, they're more efficient. Okay, so measured in many different ways, we've published on some of this stuff. So it turns out one of the issues with cognitive reserve is that if someone has low reserve, their cognitive performance level is lower, so they're closer to this cliff of falling off, saying, if you're demented, if stuff accrues in the brain, you don't have these other networks to help support you. So ultimately, you come to the threshold of not being able to function quicker. People with high reserve start off higher, okay, so they can sort of stave things off, but ultimately, when people fall off the cliff, they fall off the cliff. So it turns out that people actually, in many ways, progress faster. So what is age-related cognitive change? That's something we have to define. So it turns out, as we age, one of the major things, on average, that happens to people is that they get slower at processing information. So their ability to take information, process it, manipulate it, make decisions about it, slows down, okay? Which means that over time, their rate of learning slows down, on average, okay? But in the same way, their rate of retrieving information they've learned, if you've written it to hard disk, and sometimes you're like, oh gosh, what's that person's name? Or, I know it's at the tip of my tongue, and then you walk away, half an hour later it comes to you. That information was not lost. You just had a hard time retrieving it at that moment, okay? So that does happen also, so you can have some blocks. It turns out they call this fluid intelligence. So over time, generally, that decreases for most people. And it generally starts decreasing in your probably 20s and 30s. Okay, so, all right. Now, does that mean that you can take somebody, an 18-year-old with a very, very high IQ, and I'm not the sharpest tool in the shed, but could that 18-year-old with a really, really high IQ do what I do? No. The world is still run by people in their 40s, 50s, 60s, 70s, and 80s or older. Why? Because even if I teach that 18-year-old neurology, cognitive neurology, Alzheimer's dementology 1.0, I have 25.0. I have that software that is honed to do this particular task. And you cannot substitute for experience and that kind of learning. So it turns out crystallized intelligence actually goes up as you get older. Vocabulary can get better. And basically, greater experience and wisdom results in more sophisticated, practical, and effective strategies to perform in your daily life. So you can have actually various kind of trajectories. You can have this pathological trajectory of dementia, MCI, you can have normal aging, and we have super agers. There are people who, you know them, incredibly sharp, functioning really, really well, physically, mentally, socially, in every way. We've got to learn about them too. So there are different pathways, and how can we put ourselves more on here than here? Like I said, I have so many slides, I'm not going to show all of them. I'll flip through some of them, because ultimately we want to finish on time, and Linda, we have till 9:15, is that correct?
Well, yeah, we'd like to take questions.
Oh, I'm sorry, not till 10. Oh, you want till 10, or we started 9:05, 10:15. Okay, good, 10:15. All right, so one of the things that has happened more recently is that we understand again that there's this long period, that it's a long road, and we can actually use biomarkers. What are biomarkers? Biomarkers are things you can measure, whether it's your blood, your urine. So for biomarker, for example, for stroke is hypertension. So if you have high blood pressure, that's a high risk factor, right? And we can measure it very easily. We have these things now, some of them, for Alzheimer's dementia. They're more experimental, and we're understanding that we want to incorporate this in clinical trials and in some cases clinical practice. So what's the definition for dementia? Let's just, okay, it's something that is a change in cognition or behavior, okay, that interferes with function, is a decline, and you can't give it to people in the setting of being confused and delirious. So if someone comes in and has a urine infection or has their knee replaced and becomes incredibly confused in the hospital, you can't say they have dementia. But guess what? They've at that point, that's a stress test for their brain that they've actually not done well with. So those people you have to actually watch and think about what it is that we're sitting right there at the edge, that the reserve got pushed over. Okay? So we actually have to know people, their career accomplishments, their social responsibilities, their hobbies, the normal reactions to things, what education they had. Unless you know that, how do you know there's a change? And can you just get that from the person that's coming to you? You can't. The brain perceives the outside world and internal stimuli. So many people may not actually perceive that there's a change to that degree. So you need to have that information from the individual, but also from a knowledgeable informant who knows them well. Okay? So by definition, we want it detected and diagnosed through a combination of history taking from the individual and a knowledgeable informant. And you need cognitive assessment at the bedside by somebody. So guess what? I just can't take your blood right now and say, oh my goodness, your index went up, you're demented. We still have to know people, talk to people, understand people, know where they've come from, do the test, and then put all that in an equation to treat them individually, okay? All right, so we need two kinds of domains. One of them can be cognition, so impaired ability to acquire, remember new information, for example, so being repetitive, misplacing personal items, forgetting events or appointments, getting lost in familiar environment, those are symptoms, okay? So mainly things like the ability to get new information, stuff from 30 to 40 years ago, their ability to memorize, and my father can still tell you poetry. Still, he knows thousands of verses still. Okay, he won't remember 3 minutes later what we did or what we said. Okay, executive functions. So poor judgment, reasoning, organization. So including inability to understand safety risks, taking unusual risks, giving money to telemarketers, inability to manage finances, a whole bunch of these other inability to understand consequences, basically. visuospatial dysfunction, inability to recognize faces, objects. There are variants of Alzheimer's and also Lewy body that actually starts with people having inability to actually see things very well and integrate the big picture on things. And language. So, having a lot of wrong word things, and like I'm right now struggling, I'm substituting the wrong things and word finding stuff like that, and speech becomes vacuous, and a lot of times understanding becomes poor, so people keep on going and thinking, well, maybe the hearing's bad. They're not seeing maybe the vision's bad. Guess what? Yeah, improving the hearing and the vision will help, but it's not the root problem. The root problem is the brain's not processing. And when you get degraded information, the brain is actually worse at understanding, putting the patterns together. Behavior and personality changes. So everything like uncharacteristic mood fluctuations, agitation, impaired motivation, having less initiative, loss of drive, being withdrawn, decrease in previous activities, loss of empathy, saying things that are inappropriate or inconsiderate, being obsessive, compulsive, hoarding, all these things that are very, very, this is very difficult to deal with. Very difficult. And the differentiation from MCI requires a determination of what your previous activity was. So you still need to have a clinician who does this work. Okay, I'm not going to go through Alzheimer's disease. It's going to be there, but again, generally gradual onset, okay? And it doesn't just have to be memory that's affected. It could be, again, language, visuospatial function, executive function. And in young people, this is a big one. So I see a lot of patients who are very, very young. That's what I specialized in, especially in Mass General, and even now. And you see this same history of 7, 10 years of changes in sleep, mood, anxiety, inability to multitask. Memory sometimes affected a little bit, but not very much. And oftentimes they're struggling more and more with work, and they have lots of demand, they have young children, all this other stuff. Coworkers oftentimes are helping them. A new boss comes along, and they get fired, usually. That's a very, very common scenario. And people say, well, they're depressed, they're crazy, they're anxious, all these other things. And it's remarkable after several years to come to see me, and I tell them they have Alzheimer's disease, and they hug me, because you can give this diagnosis in a compassionate way, and now they understand that there is something that actually was biological. Okay, so what I can tell you about these biomarkers is that we can measure some of these things from your spinal fluid, okay, from doing a lumbar puncture, right? Or doing this imaging with PET scans. And it turns out that in years before, as I showed you, before you get dementia, some of these are high and increase your risk. So you can look at regular glucose metabolism in the brain with a certain kind of PET scan. You can also look at, now you can also look at spinal fluid for tau and tangles. And experimentally, we can now do with PET scans. And ultimately, we can also see structural changes where parts of the brain are shrinking. Generally, as part of the evaluation, we do an MRI to exclude some other things. Tumors, look how much people have had strokes or vascular changes. But sometimes we get a clue by areas that have shrunk also. But you don't just diagnose it with one scan, right? So it's the whole clinical picture that's important. And ultimately, people have their cognition and function affected, and that's when you get the diagnosis, pretty late. Okay. So primary prevention, what does that mean? It means basically you delay onset of the pathology. Can we do that? I don't know. Here we go. So I told you about this cognitive reserve, right? This is a study that was done with colleagues of mine at Harvard and at Brigham Women's Hospital and Mass General. Basically, a complex slide to show that actually if you have amyloid in your brain, okay, generally you do worse, but if your cognitive reserve is high, your scores in cognitive testing are still higher. So somehow this cognitive reserve is protective against amyloid-related cognitive impairment. So if I could give you an ampule of cognitive reserve, it would really help you. Okay, all right. This is another study that looks at PET scans, and again, basically shows the same thing, that in the presence of early Alzheimer's type of pathology that alters this way the brain is revving and using oxygen and glucose in parts of the brain, people who have higher kinds of reserve have a different pattern, and a pattern that it seems more protective. Okay. So ultimately, it's a combination of things that are protective, and you want to slow down vascular and neuronal damage in your brain to tip that balance later in life, hopefully. Okay. I'm not going to go through all this data. I'm going to tell you that this study by local colleagues here, actually Deborah Barnes and Christine Yaffe at UCSF, basically says that, if you take a whole bunch of these risk factors and you can treat some of these, then possibly, actually, the projections are that you can decrease Alzheimer's and dementia. Gosh, I'm having a really hard time getting this advanced. Okay. You can probably reduce it by 10 to 20% per decade. That's a really, in a societal way, that actually makes a really huge impact. So we need to do studies on this, and we need to actually do large-term studies to look to see if we modify these things, are people having less dementia? That's really, really important. This is about cognitive training. The bottom line is that when people did cognitive training, even for 6 months, 18 months later, they had some benefit on certain things, okay? So I won't go into that. This one has to do with physical activity, again, suggesting that people who actually had subjective memory impairments also had this effect of beneficial effect over a year later from having physical activity. This one has to do with Mediterranean diet, okay? Again, suggesting that it can lower your risk of cognitive decline. But the best one so far is one that it's a large one done in Finland with academia and combined with the government, that looks about 1,300 people aged 60 to 77 on average age of about 70. And what they did is they did all 4 things combined. They did the exercise, they did nutrition, they did vascular risk reduction counseling, and also mental exercise. And their 2-year data just came out that basically shows that this is the group that had this multi-level intervention. This is the control group that didn't. It turns out if you were in a control group even and getting general information, you tend to do better over time, okay, on average. The biggest benefits on total cognition were mostly due to executive functioning, this ability for you to multitask, organize, which is highly, highly correlated with you being able to function in your daily life, and processing speed. So people really benefited in those major domains. The benefits on actual memory function were lower, but again, this is just a 2-year study in relatively healthy people, right? So what about 5 years or 7 or 10 years from now? These could be markedly different in how people decline. And in this one, they looked at people who actually had major declines in their score. Remember, I showed you averages. On average, people did better, but there are people who don't do better, right? They decline. It turns out if you're in an intervention, your relative risk of decline was much less. So again, even in 2 years, suggesting that doing multiple things together helps. Okay. So increasing cognitive reserve, what do? You learn a new language, do you play bridge? The bottom line is something effortful. It has to be effortful for you. Okay, it has to be novel and effortful. And you have to change it up a little bit. So if you want to go back to playing bridge, it's a great game. It's hard, and it's going to tax you in many different domains. And it's social. So that's it. So the bottom line is that we have no definitive evidence that this decline in dementia can be retarded because we haven't done the studies. We haven't had the money, and we haven't done the studies. But there's certainly a lot of smoke there. And if we can modify these risk factors, and particularly do it in a multimodal approach, the cost probably is relatively low, and the risks are relatively low in the things I told you, and at least the proximal benefits seem to be moderate. So we need to do this stuff and do the studies. And at the end, we'd like to do some of this stuff in the US. And if you're interested, I'll show you, we're going to be developing a cohort of people who are older, who, especially if you have a family history, that we want to actually slowly over time measure your cognitive function and other functions, and then suggest interventions over time. Secondary prevention, so people who already have some accumulation in the brain. I'm not going to go into this very much, just to tell you that there are several trials that target people who either have amyloid in their brain, aren't demented, or have the mutation, right, just like the people in Colombia, right, but they haven't developed the dementia yet, or have other genes that we know are going to make people, let's say 50, 52, 55, develop dementia. And in those folks, the idea is to give them medications that affect amyloid. Because basically, we've pretty much failed when we do it in the later stages. Okay. And there's some other trials that are looking at affecting the ApoE4. Okay, so some trials are ongoing. We need more trials. What do we do now? We do tertiary prevention, which means people already have the organ failure. And what do? We try to treat them with a combination of things. So what do we do? The bottom line is that treatments have to be individualized. They have to be multifactorial, and when they are, they're meaningful. And your general goal is to slow down decline over time. Okay? You can't oversell it. You can't say that, I know you're going to be better the way you were 5 years ago. That's just not true. With what we have now, we can't do that. But over time, actually, I'll show you some data. A lot of people can be stable or get even better in some domains for quite a while. So where's our data? Okay, cheap and rapid screening of cognitive impairments. Your reflex and ability to respond to changing environment challenges seem fine, Mr. Hart. So we can't detect it this way. It's not ethical. We don't have things that are this simple. But the bottom line is that the very first thing you need to do to give people care is to diagnose people. So if I don't know you have it, how can I give you care? And again, there's that big group of people who are over time requiring more care and more care and more care, and we need to diagnose them and give them the right environments. Ultimately, we need to give non-pharmacological interventions. Okay, you guys know all about that, and in our dementia course, like I said, this talk is given over 3.5 days, from 8 a.m. to like 9 p.m. So you're getting a fire hose of information right now. Pharmacological, what do? We first eliminate bad medicines. So people aren't able to sleep, they take diphenhydramine. What is it? Benadryl. Guess what? Is that good for brain? No. It's the absolute opposite of what donepezil Aricept does. Okay? People accumulate medicines over time. Each one of them, is bad in combination. It's really, really bad. So that's one of the first things we do. We give them a combination of medications that are approved for Alzheimer's disease and also for Lewy body dementia, to treat both the symptoms and to slow clinical decline. And ultimately, where the rubber meets the road, and are the caregivers. You can have the best formula for a given person, and if that is not translated through the patient, and particularly the caregivers, it doesn't mean anything. Okay? All right. So I won't tell you about these specific medicines. This one looks at acetylcholine. In this one, we only have one called memantine, and it works on glutamate, another chemical in the brain. Okay. The medical foods, not so much, unfortunately. We use a bunch of other things, including antipsychotics, sometimes off-label with a black box warning in some people. We have to really resist doing that, because in most people, it's really, a last resort. There's data for vitamin E, which I will post for you. I won't go through it with you. And all these other things, unfortunately, have failed. Okay. In general, what happens is when people come to clinical trials, whether it's 6 months or 12 months, you basically, if you come in, on average, actually, you get a placebo effect. So being in the clinical trial is actually generally pretty good for you, to some degree. And then you may get a bump like this, whether you're measuring cognition, function, behavior, or overall decline. Of those, behavior is probably the most difficult. This is a study that we published recently. We took a whole bunch of the different trials from industry, looked at whether, if you're on placebo, is it better? Is it on donepezil or medicines that cholinesterase inhibitors? Or is it memantine better, or the combination? Guess what? We looked at decline, we looked at benefit not just at the end, but over the whole treatment period. And the bottom line is that whether you look at cognition or overall, you get this gradation. Placebo, memantine, vonaprazil combination. So you're better off being ultimately on 2 medicines, okay? And we also did the study at Mass General years ago that in a long term, over several years looked at people, and over several years, if you have the diagnosis right, what happens, your cognitive function, if you don't get treated, declines. If you're on 1 medicine, it declines less. If you're on 2 medicine, it declines less than that. So long term, on average, that's what we're hoping for, okay? Same thing applies for function, even more, actually. What about nursing home placement? These are colleagues. So these studies were not funded by industry. We didn't take industry money. We just wanted to know what was going on, okay? Same thing with this one. This was also the Pittsburgh Alzheimer's Disease Center. Basically, they looked at nursing home placement, and they looked at if you weren't treated, if you were on 1 medicine or 2 medicines, and no matter what you looked at, basically you had a 3 to 7 times less probability of being placed if you're on the 2 medicines. It doesn't mean you don't get there. It probably means that you're sort of expanding the middle parts of the disease. Okay? All right. Vitamin E, it's there. Basically, data shows that it supports function for the most part. So this is a large study, again, not supported by industry. Vitamin E, who's going to support that with industry? But this is what it showed, that high doses, twice a day, less decline in function. This was a study that was not a good one. Years ago, they came back that said vitamin E maybe is bad for you, but actually the Alzheimer's patients were the ones who didn't have any harm at all. And this is a new study that came out from the VA recently that says basically you decline 20% less per year if you're on the high-dose vitamin E. And this study was about 2.3 years, which the benefit basically was about 6 months worth. Okay, it doesn't mean it stops, it just puts you on another trajectory. Okay. The problem is we don't know what the sweet spot is for any given person. So I don't know whether, you may need 5 milligrams of donepezil and, someone else may need 10. And as the disease goes along, how to increase that. Over time, people need more. But the sweet spot, that's where clinical judgment comes in. And, whether people need, antidepressants, anti-anxiety medicines, other things like that. So you need to know what the right is for the individuals. And all the data I've showed you is in groups of people. So on the average patient, on the average individual. Are you average? Are you average? Are you average? Is anyone here average? No one's here is average, right? If we took everyone's hand size and shoe size here, and we said, the average came out to be shoe size of, 8 and hand size of 34, and we ordered 100 of those. When we put it in here, everyone would be, like most people couldn't wear any of that. It would look terrible, right? And that's just hand size and shoe size. Imagine brain chemistry, which is actually, changing over time. Okay. So what else do we do? These are some of the things we do. Try to reduce stress. Stress is bad for the brain. It puts you in this basically fight or flight where you're not repairing things, okay? You want to be relaxed, where it's promoting making new connections in the brain. You want to avoid excessive alcohol. People forget sometimes, and the effects get magnified. Sleep is very important, even now for us, and particularly later on when you're showing symptoms. Exercise, if I had a pill to give you that had the benefits of exercise, it would be a miracle drug, but I don't have the pill. So you're just going to have to do it the hard way, okay? And it's not nothing. It actually, we know it promotes growth in the brain, vascular flow in the brain, promoting synapses in the brain. So, that's something you can do on the cheap. Okay. Wait, cancel that. I guess that's help. All right. The perspective, big picture. Dang, where was I going? This is Superman, later years. I do not have anything that's going to reverse things. Some people, we have improvement or stabilization. Usually our studies show that over 6 months to 24 months, that can be reasonable expectation. But for the most part, we're trying to delay long-term decline at this point with what we have. And I don't know what the individual trajectory is for any given person. So when someone says, well, I've declined, all I know is that probabilistically people would have declined more. And the issue is we're measuring things over a background of aging and disease and decline. So that's why people have these perceptions that maybe the drugs don't work as much. They do work, it's just that people do decline over the long term. This is unfortunate. This is a gateway littered with the drugs that have failed over the last so many years. And we need people to come into studies to help us to understand this. Otherwise, we're not going to have any new therapies. I'm not going to go into all the stuff. I'm going to put the stuff in there for you so you can look at it. But we have many different ways of attacking amyloid in its production, in whether it aggregates. We use antibodies now. We're trying to do it earlier when people are showing amyloid in their brain, and even somehow affect their toxicity. Same thing with this tau protein. Okay, and these are just a bunch of medicines that are being looked at. You can get information to Alzheimer's Association for TrialMatch if you're interested in clinical trials. Okay, Alz Forum is a good place to look at stuff. Clinicaltrials.gov, put in Alzheimer's, Lewy body dementia, things like that. And you can also call us, go online, email us, and if you put Ray Dolby Brain Health Center, Google whatever, you'll find the website in the top right. Actually, you have this email and stuff. If you're interested, send us a note saying we're interested in becoming part of cohorts that we're starting probably in the new year or so. Mr. Osborne, I need to, my brain is full. And you see the brain was small, so low cognitive reserve. We need to increase that brain size. In the last 2 minutes, I'm just going to sum up. We don't know the whole link between these proteins, whether it's Lewy body, Alzheimer's disease, and the emergence of symptoms. They're probably necessary but not sufficient. There's this whole multiple things that go into organ failure for the brain, particularly when you're older. And it's some balance between vulnerability and resilience. And that's why you can't also take hope away. When you take somebody who has the disease or condition, maybe they have dementia now, and you improve their sleep, give them medications better, put them on medicines, I do not know whether they're going to be a super responder to this stuff, whether they have some genetic predisposition or other thing that is going to really blossom. And I can tell you, for my dad, when I increased some small doses, or we did, he would have incredible responses. Now, sometimes it actually made life more difficult because it was like, a car that, used to have 12 cylinders, now only have 4, but really didn't have really good steering and brakes. And then suddenly you revved it up, you brought it back up to 8 cylinders again, right? But it's a balance. Loss of memory and changes in function and behavior and judgment and movement are not, they indicate something. It's a big change. And they need to be, they're not a normal part of aging. And they need to be investigated. And generally, if you do it in an individualized way, you appeal to people's sort of like, what do you want to do over the next so many years? How do you want to live? And you give them information, you respect them, and you give them autonomy. You help people make the right decisions over time. Okay. And as I mentioned to you, the treatments are multifactorial. There's not just one formula. You have to do it all. And it's really, really important to diagnose and possibly treat, because ethically, we have an obligation to do that, to not do harm, to allow people to be the masters of their own fate, for justice's sake, because it should be available for everybody. And ultimately, what I've talked to you about generally is relatively safe and well tolerated. And these are some of the different approaches. I'll put it out for you, but everything from lowering the risk with physical and mental exercise, neurotransmitter approaches like these medicines we talked about, and all these other things that are being investigated. So we've had at least 10 or more phase 3 trials costing hundreds of millions of dollars, if not billions of dollars, failed for the last several years. And we need to intervene probably before there's widespread destruction. Delaying dementia by 5 years would reduce projected Medicare costs by 50%. And guess what? Do we wait in other symptoms, in other conditions, until major symptoms to occur before we treat, right? Do we say, oh, I'm sorry, I'm not going to give you the treatment until your cancer metastasizes to everywhere. Then I'm going to start treating you with 2 drugs or 1 drug or doing other stuff. We don't. So why do we think this way in dementia? So we need to change the thinking of society and clinicians also. In the future, we'll probably do a whole bunch of things, improve diagnosis earlier, personalize things as we understand better, what are individual differences between people, and use a combination of medications that are supporting the brain, like the current ones we have, with better function maybe, and somehow disease modifying, changing the underlying course of the disease. And we want to do it earlier and earlier and earlier. Okay. So do everything. That's the bottom line. Do everything. Can we cure? No, we can't cure. Sometimes people come to me and they think it's Alzheimer's disease. It's something very rare. Actually, that happens. There are certain immune conditions that can mimic. But I can tell you that we can often help. We can always console. We need to do that. And this came out of actually tuberculosis years ago. It was attributed to that. And guess what? We actually manage that condition much better now than we used to. So I think there's hope. I think we're on the right path. I'm really glad you're here to take the step with us. And I think the glass is more than half full. I'm a scientist, but I think that's what it is. And I couldn't have told you that maybe 7 or 8, 10 years ago. Even I'm relatively younger than a lot of my peers. I remember going up to these panels years ago, and they would say, we're going to have something major in the last 5 years, next 5, big bullet. And I'd scratch my head and say, I'm just not really smart because I don't see it. I don't think we're going to have a magic bullet. We're not going to take people at the end stage, which is organ failure, and make them the way they were 5 years before. But we need combinations of things, and we can do it step by step. And if you see this license plate, it's my license plate. It says Cure AD. It's not see you read. And I just applied for it for California too, so it's outside. Thank you very much.
Not only is my brain full, but my heart is full with gratitude that you shared such a comprehensive presentation with us and that it will be made available on the Brain Support Network website. I think with this kind of voluminous information and data, it's hard to process unless you've actually heard the presentation. So I think having seen it, you can share it with family and kind of guide them through the slides. We are going to be taking questions from the floor. We have mics on either side of the room with Robin and Sharon taking charge. Does anyone have a question?
Just remind me about recording.
Yeah, again, we are video recording, so if you want to ask a question from the floor, we invite you to come out to the aisle.
And from our center, Emily Mitchell is here. Emily, and she has a little table outside, so if you want to get some information from us, you can.
We do. We have a table set up outside. Actually, let me start by asking one quick question. Yesterday on Science Friday on NPR, I heard a story about tinnitus and untreated hearing loss being a contributing factor to the potential risk of Alzheimer's, or is it just...
What?
That tinnitus...
I can't resist. See, that's poor judgment, change in personality, unfortunately, that's not a change for me.
Okay.
There are many different, there are many different pathways that go into this. And oftentimes we like to say it's one symptom, one treatment, whether it's blueberries, curcumin, whether it's alcohol, whether it's coconut, oil, or things like, it's depression, or it's tinnitus. So these things can happen. There are many different pathways that go into that. So tinnitus can be due to many different things. It could be an infection, it could be inflammation, it could be actually a structural lesion, a tumor. But in some conditions, like Meniere's disease, it's neurodegenerative. So the answer is if there's if this association is really, really small.
Okay.
And what I can tell you is a very common complaint is sometimes people are dizzy. I'm dizzy. And it's not necessarily true vertigo, like the world is completely spinning up and down. But what happens is that sometimes it's where our networks are processing information, they are incredibly timed. And how things come from one side to the other are very much time locked, and there's an order to it. And as things go to disorder, as one side starts not processing well, the brain starts feeling like there's something off, and oftentimes people will verbalize that as I'm dizzy. So that's something that we hear much more. Now, I'm dizzy could also be you're dehydrated, which is actually one of the major things you can do is to hydrate yourself and hydrate patients. Because these variabilities, these fluctuations that actually happen, all of us fluctuate. Not every day do you get up and you feel as constantly sharp and you're moving as fast as every other day. Michael Jordan didn't always score 30 points in every game, and Tiger Woods, when he was really, really good, didn't win every tournament, right? But they fluctuated. And as we get older, we fluctuate more in our cognitive abilities. And when people have these conditions, they have less reserve, so they fluctuate even more. So that it's like almost like this radio that's out of tune. The old radios, not the new ones that are analog, right? It would kind of drift out of tune, and then sometimes you come back in tune, and they're like, oh my gosh, there's nothing wrong. I can tell you, my own family members were telling me, there's nothing wrong with your dad. He's as sharp as ever. Well, you don't live with him. You don't know that he's out of tune so many times. So there's many different symptoms that are
I think we've all heard that one.
Yeah.
Okay, Robin?
Hi, I'm wondering if caregivers and even maybe some of the patients were able to do journaling throughout their process, could that help these studies in the future, or is that not qualified as real study material?
No, I think journaling is good for many reasons. I think it's we didn't go into how really, really important the health of caregivers is. So all the effect sizes I showed you, if you actually looked at supporting caregivers, it's got equivalent effect sizes for actually having the patient do better and not go to a nursing home later. So it's just as good as our drugs and anything else is to support the caregiver. So journaling does many different things other than the fact that it allows us to have ways of looking at these fluctuations in information, but it's a way of also coping. Hopefully, we're going to have some humor later, and it's interesting, we wrote a scientific book, and I actually wrote about humor. It's really, really important to cope with things. And what do you say? Like my dad would come up and accuse all of us of taking his his hat or his glasses, and be yelling, and would be upset. And someone who would never ever be upset about anything. I'd seen him raise his voice once in my life, let's say. Okay, and what do you say to that? And you look at it and you say, well, I did it's actually on your head. So you look at me and say, well, who put it there? Right? So what do you say to that? As far as studies go, generally things in studies would have to be a bit more systematic, so if it's journaling, it would actually be directed journaling in the sense that we would want you to report certain things in a very systematic way over time. And actually, one of the things we want to do with our cohort, if you're interested, if you're a caregiver, is not only do we have education programs, etc., but this cohort we're talking about aging, etc., we're interested in actually in the health of caregivers and to see over time how they're changing, because there's a lot of data that actually caregivers, their function and their cognition changes more rapidly than we would expect for their age and education, etc. And what can we do to support that?
Hello, my question is about the medical field, the education of the future doctors, and the continuing education of the doctors that are now handling many of us older patients. Their diagnosis...
Woefully inadequate.
Yes.
Woefully inadequate.
And that is my question. Do they need to get...
Embarrassingly inadequate.
Right. Continuing education, like many of us in our fields, we need to do that all the time. But what about doctors, especially with dementia?
Right, so if you actually do a search for Harvard Dementia Comprehensive Update and put ATRI in there, you'll see that the biggest course in the world for dementia for clinicians is something I've directed for about 6 years. We attract hundreds of people from around the world, except 4 days, all day. The bottom line is that it's, I probably educate, 5,000, 8,000, 10,000 clinicians over per year, depending on the medium. We're doing better with it. There's no resources for it. Who funds it? No one funds it. No one wants to fund this kind of work. The Alzheimer's Association supports some things, but They focus a lot more, even through the Alzheimer's Association, and I'm involved with them, and it's a great organization. Unfortunately, isn't as much through putting the education into the clinicians, and that's where we actually really need to focus on. And we're not. How do we get funds for this? That's the big issue. Many of us are interested in this, and really know that it's not like subspecialists like myself who are going to be in the front lines. It's going to be the primary care folks who are going to be in the front line, and they have to recognize it, and they have to ultimately manage it over time.
But I find that doctors are diagnosing it or saying that it's more of a social issue, or they're just, let's give them some medication for, anxiety and things like that, instead of referring them to a neurologist or somebody.
The reasons for that, I have a talk that's an hour long that talks about just the reasons for that. There are individual reasons for that. There's actually reasons that are related to family members not recognizing symptoms, patient-related issues. There are clinician-related issues, including time and lack of education and knowledge and basically ignorance. There are system-wide issues because unless you have an endowment like we do, how can you give the care that's necessary? That's multifactorial. It includes social workers, neuropsychologists, specialists, and it's not reimbursable. People, for the most part, you're not reimbursed to care for people. You're reimbursed in the medical system to do procedures, and that's a major problem.
Yeah. Question on this side?
Hi. I just want to take a brief second to thank you. I'm very, very moved by your talk and the heart and soul that you brought to it, and I will do what I can to spread it.
Thank you.
My question is, I work with students with learning disabilities, elementary age, who already have executive functioning issues, processing speed, et cetera, et cetera. Is there any evidence, either observational or clinical, that they are at higher risk for developing something in the umbrella of dementia? And if so, would all the recommendations for exercise, for cognitive learning, novelty, apply to them as well?
Sure. Again, that requires really, really long-term studies. There are some studies that have looked at cohorts in Britain, for example, and generally, if those things have affected their learning, their educational attainment, IQ, then they're at more risk because they have less cognitive reserve. So the answer from that standpoint is yes. I think one of the major things that come out of this, I think, is that we need to do a lot of those things earlier in life and even midlife. Probably if you had to do one thing, it would be exercise. Yeah, if I had to choose one thing. So, thanks.
Linda, I think we should just do one more question, and then maybe Dr. Autry can stay.
I'll be around, so
Okay.
you're welcome. I'll be in the
Perfect.
patio and come over and ask
One more,
questions.
please.
One more. We'll do your side, because I think she was there first.
My question is basically about memantine and galantamine. My patient was diagnosed 8 years ago in another state, and I moved here 1 year ago
Okay.
and took the care of a geriatrician, an internist who calls himself a geriatrician, and he immediately said to me that the medications are only good for 3 to 5 years. Take him off memantine and put him on galantamine alone. What are the basic differences between these two, and
They're
can you
completely
just
different.
stop one right
Yeah, they're completely different. So galantamine is in that first category of cholinesterase inhibitors. So it's in the category with donepezil, Aricept, or Razidine, Exelon. It's in that category. So it works on only one system. Memantine works on glutamate, which is a different system, and they're complementary. And so in some sense, we don't have super long-term studies, but we don't have, so the absence of evidence isn't the evidence of absence. So generally, what I showed you for over about 4 years or more, from our studies at Mass General, if you took the two medicines, you were on a higher trajectory. I can tell you that, for example, when these medicines got to become generic, and the other medicines are generic now except for the patch, which basically in England, for example, when the National Health System years ago was paying for even the Aricept, the Donepezil, they did really, really poor studies that people like myself fumed over it, and they were published in really prestigious journals, and they were incredibly bad science as far as design goes. But it allowed ammunition for the funders of those studies, which is the National Health System, who at that point was paying for these medicines, to say, we're not going to pay for it, basically. And it took another, even though there was evidence that if you took some of these people off of, for example, cholinesterase inhibitors like Donepezil, people crashed and did worse. And then even if you put them back on, they never quite came up to the same trajectory. It took another 10 years for them to do another relatively poor study. And even that very first poor study showed some benefit. It's just that they said, well, the costs were, maybe it didn't justify it. It took another 10 years to actually show what we'd already known 10 years ago, that actually people need to go on the medicine and stay on the medicines. And they just did another analysis to show, again, if you took them off, they ended up in the nursing home a lot faster in a year. So, when memantine is generic, we'll have even more information. It'll become, 5 to 7 years from now, probably a bit more darling. I can tell you what happens for my father. My father's on both of these medications. He's on vitamins, he's on vitamin E, and he was on them from relatively early on for combination. I think so. After a certain stage, absolutely. Yeah.
Thank you, Dr. Atkin.
Thank you very much.
Thank you very much. So as promised, a little bit of a stretch break perhaps at your seat. And I'd like to actually invite all 4 of our panelists up to the stage. And our first speaker today is my friend and fellow board member of the Brain Support Network, Helen Metzger.